in-depth exploration of the world of women today with Sandra Elkin.
Good evening and welcome to Woman. Tonight, part one of a discussion of sex therapy. With me is Dr. Helen Singer Kaplan, who serves as head of the Sex Therapy and Education Program at the Payne Whitney Clinic of New York Hospital, Cornell Medical Center, where she has developed and directs the clinic for brief treatment of sexual disorders. Dr. Kaplan is the author of the Illustrated Manual of Sex Therapy. She also conducts a private practice in psychoanalysis and sex therapy. Dr. Kaplan's new book, You and Sex, a book on the biology and psychology of sex for young people, will be out in the fall. Helen, welcome to Woman. I'm delighted to have you here.
It's a real pleasure to be here.
Helen, could we talk about the kinds of therapy that are available and that are usually used to treat sex dysfunctions, such as analysis, marriage therapy, and behavior therapy?
Well, I'm really glad you put it that way, because recently there's been so much over-publicity for sex therapy that everybody, I think, is beginning to think that everybody with a sexual problem needs sex therapy, and that isn't true. A sexual difficulty has to be very carefully evaluated, and we have treatments that range from psychoanalysis, behavior therapy, sex therapy, marital therapy, and even surgery and hormones. So we have the whole range of medical and psychological treatments available for each, appropriate, after the appropriate evaluation has been made. Now, which one of those do you want to hear about?
Well, I guess what I want to know is whether you think that it's important to go to a sex therapist, and I'm beginning to get a clue that you don't think it's all that important.
Well, it's terribly important if you have a sexual problem to become educated, in other words, to have it evaluated intelligently so that you can see either that you can live with it, or maybe you don't even have a sex problem when you think you have one, and if you really have one, to get some idea what the outcome is and what kind of treatment would be appropriate.
If you go into analysis, which is years and years and deep therapy, and you only have a mild disorder or dysfunction, I mean, isn't that a waste of your time and money?
Well, if you properly evaluate a sexual problem, let's put it more specifically, of the people who come to our clinic or to our group for an evaluation, about 50% would probably respond to the brief sex therapy that you've heard so much about, and that's what they're suitable for. A smaller percentage have very deep either marital problems or psychological problems that wouldn't respond to sex therapy, and they need either marital therapy or psychoanalysis. And another small group don't even have a sexual problem, they just thought so. They read so much about sexual functioning, they have all kinds of fantasies of what good sexual functioning should be, and they should just be sent home and reassured. Others have organic problems and need hormones, and I said some people benefit from surgical operations and everything. So you really need an expert to tell you what kind of therapy you need. The person can't make their own evaluation.
Can you go to an analyst and be fairly certain that he will say you only need brief intervention here?
No. You see, most people will recommend what they can do. If you go to a sex therapist, they will recommend sex therapy, and if you go to a psychoanalyst, they will recommend psychoanalysis, and so forth. So you really should go to somebody who, or a place where everything is available, where it can be evaluated properly and get the appropriate treatment. It certainly is a waste of time if a woman can't have an orgasm, say, for rather superficial reasons. If she goes into analysis, that's a terrible waste of time, and it probably won't work.
That's pretty much been the case, though, hasn't it? Up until recently, when certain kinds of sex therapy have been developed.
True. We used to think that everybody who couldn't have an orgasm was suffering from very deep problems. They hated their father, or they were afraid of their mother, or they really wanted to be a man, they hated the female role, or some rather deep inner conflict. And it was really Masters and Johnson who pointed out very correctly that there could be superficial reasons that are much more easily removed and don't require analysis. In fact, analysis is inappropriate for that. See, there's only one reason people can't have orgasms. Just one.
Just one?
That's all. Can you guess
You
what
have
it
to
is?
tell. No, you have to tell.
Oh, okay. And that's anxiety. anxiety will stop that reflex cold. But there are many sources of anxiety. See, and the body doesn't know whether the anxiety is coming from, oh, gee, I have to hurry up and come fast, or he'll be disappointed with me, or whether the anxiety is coming from, I can't trust him, I can't let myself go, he'll abandon me tomorrow, even unconsciously, or even deeper things. Anxiety is physically anxiety. Fortunately, we found that in many cases the anxiety is rather easily dispelled with some open communication, some reassurance, some education, and that's the miracle of the new sex therapy.
Let's talk very specifically about the new sex therapy and what makes it unique.
Well, when I gave that as a title of the book which I wrote, which is being used, as a text now, I wasn't thinking of my own specific development of it. What I was thinking of, that a brief, rapid behavioral approach was a new development. And that's really what I meant by the new sex therapy. More accurately, we should be talking about the new sex therapies, because since the original Masters and Johnson model, and even before that, many different varieties are being practiced. They all have one essence, however. They have two characteristics that make them unique. One is that they really don't try to fix the whole person. They really focus on the sexual symptom. Not just the genital sexuality, the emotional aspects too, but really sexual functioning, and let other things alone. That's one unique thing, because all the other therapies that have been used try to fix the whole marriage and the whole person and so forth. So this is pretty limited. And the other thing is, the other unique characteristic is that sex therapy uses a combination, an amalgam, of very specific erotic tasks that the woman does alone at home or the couple do alone at home. And these tasks bring up very profound emotional feelings usually, and these feelings are then dealt with in the therapy with psychodynamic means by the therapist. And that sort of combination of the behavioral and the psychological, psychodynamic is what makes us unique. And the third thing that makes it unique, if it's going to work, it's going to work very rapidly, within 10 to 20 sessions, rather than conventional 3 or 4 years.
How does it, is it different from what Masters and Johnson? I mean, are people
My own
branching
approach?
out? Yes.
Well, my approach is quite different, and yet it has some of the same characteristics. Because I come from psychiatry. I'm a psychiatrist, so naturally I'm more interested in the emotional and psychodynamic aspect of the person and the relationship. Doesn't mean I don't work briefly, I do. But I would be more interested in some of the unconscious factors and emotional factors that are contributing to the total picture, and work more specifically with them. I work with dreams. If I, for instance, tell a woman to go home and stimulate herself, suggest that as a means of, first of all, reaching orgasm, or at least starting to explore some of the anxieties that have blocked her from reaching orgasm, she may come in with a dream. And that dream may reveal more to me than when I say, well, how did you feel about it? She said, oh, all right, I didn't feel much, but I said, were you anxious or guilty? No. And then she tells me she had a dream of being chased by 6 men with guns and knives and falling into the pond and almost drowning. That tells me something. It tells me that this touching herself, which I suggested, might have evoked the deepest kind of early guilt against masturbation and things, and then I have to deal with that, and I will.
Do you think what you define as the new sex therapy and what you therapies and what you're practicing, do you think it's more flexible than what's been done in the past?
When you say done in the past, the original Masters and Johnson model?
Yes, or even analysis or some of the other kinds of therapy that's...
I like to think of myself as being more flexible. It's a very flattering self-appraisal.
It seems to me very individualized. Is that true?
It is highly individualized, and it uses a variety of modality. It sort of orchestrates the behavioral and psychodynamic and couples therapy. Sometimes we stay strictly behavioral, other times we delve deeply. It's much more active, flexible, and more difficult. You have to work much harder. I work much harder with a sex therapy case than I do with one of my analytic cases. I become more tired. It's a more tiring sort of...
Are the cases
approach.
becoming harder?
Yes, as we were talking about before, that's one of the interesting phenomenon is that in the beginning of 5-6 years ago when I organized the clinic, we had many very easy cases. In fact, they were so easy.
Well, what do you
some of
define
them-
as an easy case?
Well, for example, if I evaluate a couple, and when I evaluate a couple, I always try to give them something so they don't feel like they've been inspected like a piece of meat. And yes, you're suitable, you're not, with a stamp. I try to give the person something and the couple something, and I usually give some advice and some evaluation, share my evaluation with them. And very often after 3 months when an opening occurs, and my secretary will get on the phone and say, all right, we have an opening for you now. They say, oh, that isn't necessary. That was such a great consultation. For example,
You may put yourself out of business.
I hope so. That's my aim. With education and prevention, I sure as heck hope to put myself out of business. Not today, but very soon.
Why do you think the cases are more difficult? Because we know more?
Well, I think there's been an enormous, probably even over-saturation of the public media. But I don't mind the oversaturation. That's a small boredom and is a very small price to pay for the real positive educational job the media programs such as yours, for example, have been doing. Good articles in magazines, television program, books have done a great deal to educate people and sort of desensitize them. People couldn't even talk about sex before. And as I said before, the penis or the vagina can't tell if the anxiety which is blocking its function is coming from just a little ignorance and a little shyness and anxiety or something deep. And the easy cases, by easy cases, I mean cases which are people who, I don't even like to think of people as cases, but people who are not functioning well because they're blocked by anxiety, which is easily dispelled by some information, some reassurance, by the knowledge everybody is doing it, I'm not the only one. And these, also the medical profession and the health professions in general have received a great deal of education and now able to, obstetricians and psychologists and physicians are now able to counsel patients much more intelligently and are probably doing therapy on the, quote, easier cases. Would you like an example of what I mean by an easy case?
Yes, yes.
Okay. There was one, a couple came in with an unconsummated marriage. An unconsummated marriage is really not a dysfunction, but it certainly is troublesome. It means for some reason people have not had sexual intercourse, and this couple was married for about 3 years. A lovely couple, so I looked for the obvious causes. The man was not impotent, the woman was not inorgastic, they loved each other, neither one was terribly neurotic, and so in order to evaluate what's wrong, I take a very careful reading of their sexual interactions with each other. That means a very detailed history of exactly what goes on when they try or do have sex with each other, what they're thinking and feeling and smelling and everything else. And that was fortunate because it appeared in this instant that the man thought it was not masculine to take a shower or bath before having sex with his wife. And she was far too shy and came from a cultural group where women did not speak up. So she never said anything, but she was really repelled by his body odor. And this came out for the first time in 4 or 5 years in the session. So my obvious advice while I put them on the waiting list was that perhaps it's not unmasculine to take a shower. That is certainly not any sign of not being masculine, nor was it unfeminine to speak up if one speaks up gently and so forth. And whereupon he went home and took a shower and the couple were cured. That's an easy case.
Is that rare? I mean,
it's not that rare. It's not that, or it used to be fairly common where the most simple information or 2 or 3 reassuring, humane sessions could really make a considerable difference in people's functioning.
do people know more, or are you still surprised that people don't know?
I still am, even though I'm in New York City, I'm still really surprised at the lack of knowledge about genitals.
What are some of the things that people don't know, some of the surprising things that have happened to you recently?
Well, I'd have to think of my memory, but very often neither the woman or the man will really know what the female genital looks like. They won't know where the clitoris and what the clitoris is. They won't know where the vaginal opening is. They'll have all kinds of, they won't know what semen is. Some women think it's poisonous and harmful, and men will have all kinds of feelings about menstruation and pregnancy. So those are still fairly surprising things, and it's surprising that otherwise educated people will put up with 3, 4, 5, 10 years of an unconsummated marriage without doing anything about it or asking someone about it.
But that might be because of something you said earlier, the fact that we have really gotten the message that sexual dysfunction is a sign of being deeply disturbed. I think people think that still.
Their identity is people's identity is so tied up with their sexual functioning. If a man is impotent, that's not bad enough. He also suffers a terrible loss of self-esteem and thinks I'm worthless and nobody will want me and I'm no good. And that shame and thinking of the self-esteem is very, actually prevents him from seeking and getting help. And one of the first things we do is say your penis is not you or your orgasm isn't you. This is a reflex, and if it's inhibited, that we'll work on that. It doesn't mean you're worthless or not lovable or something.
In the book you deal with 3 dysfunctions that are female and 3 that are male. And I think the first one you deal with is sexual, I can't remember the first one of the female.
Okay. Well, at
sexual
the risk
unresponsiveness, is that the first
total
one?
Sexual unresponsiveness. That's
Right.
the most troublesome dysfunction.
Now, what does that mean when someone is totally sexually unresponsive?
That means that even if a man gently touches them and properly stimulates such a woman, she feels nothing. I don't mean she hasn't got a sense of touch, but touching the nipples or the clitoris or vagina, which should give you an erotic feeling, a woman might say, well, it's as though he was touching my hand. I feel the touch, but I feel no sexual pleasure, no arousal. So there is absolutely no feeling, and there is no physiological arousal. The first stage of physiological arousal in the man and in the woman is a vasocongestion. In other words, the genitals become swollen and filled with blood. That's why the penis becomes erect, and that's why women lubricate and the vagina becomes sort of swollen. The unresponsive woman or the impotent man or the man who has an erection problem doesn't experience either the pleasure or the physiological functioning. Otherwise, there's no erection, no arousal. And a woman who's totally unresponsive suffers from that particular. That's the worst one.
What are some of the causes?
Well, they range. That's a more severe one than the more common one, the most common female. I'll get back, I'm not ducking that. But the most common sexual dysfunction of women, problem women, is having some degree of difficulty in achieving an orgasm. That's the most common, and that fortunately is much easier to treat than a totally unresponsive woman. That's a difficult one.
But the prognosis for the sexually unresponsive female is not dire. I mean,
oh no, it's not hopeless, but it's probably the most difficult of all the sexual dysfunctions.
What are some of the causes?
Well, the two most common causes are deep shame and fear about sexuality that causes even a young girl, as soon as she feels anything sexual, she just represses it and wipes it out. So that's a common cause. The other most common cause is partner rejection. A woman who really doesn't love or is attracted to her partner. That, unfortunately, is a very common cause. You can't. Sometimes you can remedy that, and sometimes you cannot.
So what do you do? What do you do when you try to treat that?
Wait, I want to get to the more hopeful ones before. Then there are simply women who have performance anxiety. They're so worried about pleasing the man or having a response that they never take the time, which is normally necessary for a woman to become responsive.
And don't take responsibility for their own sexual pleasure.
Precisely. And then sometimes those are the simplest cases. The couple is just using poor techniques, or she's guilty about the use of fantasy. Those are the easy ones. As I said, there are easy ones and hard ones. See, the final common pathway is always anxiety, but I would say that's the common final pathway, but the causes for anxiety are so vast and different. The easy ones are when you just teach a couple better technique and you relieve a woman's anxiety. about expressing her need for more tactile stimulation for a little more time. And I have the couple share this information, and that very often is very helpful. And a rather gradual teaching of the couple to explore the woman's sensitive areas and erotic zones, and that kind of behavioral work along with psychological counseling is very often successful. But there are some women who are totally unresponsive who simply don't love their husbands, not attracted to them. Again, sometimes you can fix that if the lack of attraction is due on some neurotic basis, some fear of trusting him, some fear of being abandoned, some characteristic of his that he could change. Maybe he's too bullying or too defensive or something, and if that can be changed, that's rehabilitation. Sometimes, no matter what, the woman simply isn't attracted to that particular man. There's no way she's ever going to respond to him sexually.
How do people respond to that kind of news? I mean, you're not...
Well, I don't usually say that on the first 5 minutes. That's the unbalanced relationship is one of the more difficult, troublesome, sensitive areas to work with. And
probably you know on some level, probably the patient knows on some level, right, that that's the cause.
Yes, but that you'd be surprised how vigorously couples will deny that. Both the one who's not able to feel, who's as much a victim of this unbalance, as the one who's able to, is always yearning and gets no response. Both partners feel very badly about that. The one who can't feel feels guilty and pressed and badly about it, and the one who wants a response feels awful because they feel rejected. But very often couples will deny that and will say, well, if I learn a technique, then everything will be all right. And the only way to handle this is to first frankly admit it openly between the therapist and the two, and then work with that and the implications of that. As I said, that's not always unfixable. Sometimes that's remedied, and sometimes it really can't be. And then the couple has to make a choice. Is there enough in the relationship other beyond sex which still makes it worthwhile keeping, or is it really too destructive and should it be given up? And that's a hard decision.
What are the essential ingredients in a therapeutic situation for a couple with that problem? In other words, what kinds of therapy should they look for specifically? What are the ingredients?
Once they realize they're imbalanced, or once a woman is unresponsive?
Once a woman is unresponsive.
Well, the couple need to have the cause of that unresponsiveness evaluated. Whether if it's only poor technique or ignorance or some guilt. And she never said, but dear, I can't come in 2 minutes. She never got enough nerve to say that, so she's been victimized for years by herself, not even by her husband. You know, I've never yet met a man who wouldn't be happy to be a good lover and really give his partner pleasure. I've never met such a man. It's just women assume that if they express themselves at all, they're going to be rejected. And that certainly isn't true. There are, of course, harsh ways and demanding ways to ask for something. There are also gentle and sensitive ways of asking for something.
When we get into, next week we'll probably have to do this, but get into talking about inorgasmic women, I'm curious to know what the new aggressiveness that some women have to experience does to men. And we'll talk about that next time. In the meantime, though, Helen, there are some very basic fundamental things about human sexuality that we don't have definitive answers to. Isn't that correct?
Not really.
No?
There are a few things, but not
I
really.
was thinking of bonding.
Yes. The area of bonding and gender-specific differences that are not cultural, we don't know. But we know, see, it's easy for anybody to be an expert in this field because it's relatively simple. There's nothing more complex about the sexual responses than about the digestive responses or the cardiovascular responses, and it's far less complicated than brain functioning.
I guess it only seems complicated.
Because until 10 or 15 years ago, nobody looked at the sexual reflexes. Masses and Johnson were really the first ones who had the foresight and the courage to look at the sexual reflexes, but they're basically very simple, 2 sets of reflexes. And there is, as I said, it's very easy to be an expert because people assume it's complex when it isn't. I hope in 5 years, every second-year medical student knows as much as I do about this, because it's not difficult. 2 basic reflexes, the excitement reflexes, the vasocongestion, the swelling, and the orgasm reflexes. And that's really all there is to it.
And then you have to find out at what stage something went wrong, right?
Right. Now, the psychopathology of sexual relationships is complicated. What's the relationship between love and sex? What attracts people to each other? How long do we bond? Are we lifetime bonders, or are we 4-year bonders? You know, we haven't answered like monkeys. We haven't answered that. What are the basic differences between men and women, biological differences? We really don't know that. But about the human sexual response, we really know a great deal, and it's really not complex.
Do we know if monogamy is the best thing for us?
We don't. I have a sense. We don't know. What I'm saying now is a pure sense. I have a sense when people are left alone without too much pressure, like the young kids today, most people in our society certainly tend to be more comfortable within an exclusive and comfortable relationship. And when I say exclusive, I don't mean that in the strict sense of the word. I mean that in terms of commitment and interest. Most people do seem to be most comfortable that way, and that's about all we can say. Other people are perfectly comfortable alone, and I'm not going to label that pathological. And yet my sense is that that's probably our species-specific behavior. In other words, horses and cows and sheep don't form bonds at all. They will mate, and male will mate with any female in heat. Other species, such as geese and certain species of monkeys and apes, will form bonds and will only really be comfortable having sex with that one individual. My feeling is that we're like that, but I'm not sure.
Helen, we're almost out of time. We'll have to continue this next week, and we will continue Part 2, Sex Therapy, next week.
Woman was produced by WNED-TV, which is solely responsible for its content, and was funded by public television stations, the Ford Foundation, and the Corporation for Public Broadcasting.